coming to complications. So it is found in 0.06, the incidence of complications, number one. First, very important complications. These are the main primary complications that we're going to discuss, which are fluid overload, pulmonary edema, hyponatremia, and cerebral edema, which is part of the TERP-like syndrome, gas embolism, because of CO2, and hypothermia. So the fluid overload, if we talk about, it is primarily if it happens in 0.06 to 0.2% of all operative procedures. Factors which can lead to fluid overload are patient population, length of the procedure, size of the intracavitary pathology, depth of the fibroid penetration into the myometrium, creation of false track or cervical laceration. Many people, sometimes you have to do cervical dilatation. When we are doing that with the dilator, you might enter into false track, or even with the hysteroscope also. Initially, when you're learning, you have a tendency of entering into the false tracts. So these cause increased fluid absorption, leading to fluid overload. Uterine perforation leads to sudden fluid overload, type of pathology, and the medium used. So with fluid overload, what happens is the patient might land up in acute decompensated heart failure, pulmonary edema, laryngeal edema, dilutional anemia. Electrolyte and plasma imbalance, that can be hyponatremia, hypo-osmolality, hyperammonemia, hyperglycemia, and acidosis. Neurological sequelae can occur, which is slurred speech, visual disturbances, hypersomnia, confusion, seizures, and coma. Very important, how do you prevent? Always prevention is better than cure. How do you prevent fluid overload? Use iso-osmolar electrolyte fluids whenever possible. Limit the amount of preoperative IV fluids. Even anesthetists, if you know you're going to use a lot of fluids for the surgery, ask them don't give too much of IV fluids, especially when large myoma, deep hysteroscopic resection is anticipated. Monitor fluid deficit closely and halt the procedure and evaluate for fluid-related complications at a preset threshold. Maintain lowest intrauterine pressure to achieve excellent visualization. The IUP, more than MAP, is required for adequate visualization, but limit your surgical time to less than 1 hour. Use of vasoconstrictor. This is a very important point, and it's often asked in exams. Intracervical injection of dilute vasopressin. How do you dilute? You use 1 unit in 20 ml of normal saline and inject it at 2 points. So I usually take the diagonal points. Avoid the 3 and 9 o'clock position. 10 ml each are injected before the procedure. It reduces blood loss and decreases fluid absorption by 3 folds.